to discuss. The paper that I have asked her to discuss is basically on the premyopia. It is basically about knowing about the risk scoring system. We have talked about it in my presentation also. And if there are any doubts, it is basically an article which has discussed about what is the scoring system, which is beyond which you can say that this patient would progress. So if there are any questions, we can start talking about it. Yes, Dr. Shalaka. I thought you unmuted. If there are
No,
any
sir, that is accidental.
Okay. So if there are any questions, we can talk on premyopia, because I think the most important part of this whole meeting, this whole myopia thing, is that we should be able to prevent premyopes from being myope. So that is the whole point. And if we can do that, that is the successful myopia treatment. Because otherwise, bulk of our work is based on the fact that we are trying to just stop the progression.
Sir, good evening, sir.
Good evening, Doctor.
Sir, I missed most of the classes, sir, actually, because of the few reasons, genuine reasons.
Okay.
Sir, I had gone through the video, sir, and just wanted to know if you have presented only regarding the spherical plus power, sir. If there is cylindrical plus power, are they considered as premyope, sir?
Okay, so basically, whenever we discuss about premyopia, we have to make sure that the cylindrical power is in minus, and whatever is plus has to be transposed on the sphere. So if suppose there is a +1 cylinder at 90, this will be transposed as +1 sphere with a -1 at 180. Simple transposition. We are not going into transpositions. So if we go into simple transposition, we are basically trying to say that there is a +1, and this +1 is actually the hyperopic reserve. So patient is on the hyperopic side. So this particular patient, if he has, there are two important points here. One is that if there is a parental myopia, if there is a sibling myopia, if that is point number one. Point number two is if the patient is losing out on his or her hyperopic reserve very quickly. So if you have seen this patient of +1 cylinder, say 2 years back, and patient had +1 cylinder, or patient had +1 sphere with a cylinder of -1, and when he comes next to you after a year, now patient is only having -1 cylinder.
Right, sir.
And his axial length has progressed from suppose 22.5 to now it is 22.7 or 22.8. Now this patient is very quickly losing the hyperopic reserve. The plus power that patient has, the patient is losing out very quickly. So there is a very good chance that this patient would progress or would tilt towards myopia. Also, you have to ask the patient whether, if there is no parental history, whether patient is an avid reader, whether he sits a lot of times indoor, whether he is doing a lot of near work. All these factors are risk factors which will make sure that this particular patient who is on plus would go towards emmetropia, which is 0, and would gradually go into myopia.
Fine, sir. Fine, sir.
And the axial length elongation will also be seen. It's not that axial length will not elongate. Right now, we don't have, zero power halt lenses or zero power myosmart lenses. But I think gradually time will come where we will have these, pre-myopic or zero power glass lenses to prevent myopia. Right now, we are preventing myopic progression.
Fine, sir. Fine, sir. Thank you, sir. Thank you, sir.
Good evening, sir.
Yes.
Sir, do we have any range of hyperopic reserve for a particular age, or is general, sir?
Yes. So I had, so the range is from plus 0.75 to minus 0.25, minus 0.5. As I had shown in my presentation, there's a definite age. And with every age, they have tried to talk about what exactly would be the risk factors, this thing. So the International Myopia Institute has said that, if the age is less than 8, and if the plus power is plus 0.75, if the age is more than 8, 10, I think there's a slide in which I was trying to tell about what age, what power is a premyope. So at the age of 7 years, if patient has zero power, it means that this patient definitely would become myope. Also, there is a premyopia risk scoring system where they have talked about the fact that if you have this much hyperopic reserve with an axial length of more than 22.6, with a corneal curvature, with an axial length upon CR ratio, and then they have tried to create a scoring system. So that scoring system is also helpful. If you want, I can send you that particular article. And there's a question by Shalaka about BHVI myopia calculator for pre-myopes. You can use that BHVI myopia calculator. I think the only issue is that I was trying to point it out in my presentation also, that if you try to see bulk of their myopia calculator changes depending on if you change the history part. So if you change that there is no parental myopia, it will show a very less. So there are mainly two indicators that BHVI is using. One is parental myopia, and second one is obviously the presenting hyperopic reserve. These two are very, very important. But the third part is also that if the axial length is long, so that is probably not given much importance. But if the axial length is long, obviously, if you have already have a patient whose axial length is suppose 23, with even if the patient is emetro, we would feel that at the age of 6 years, if the patient's axial length is 23 or 23.4, this patient is definitely having a slightly larger axial length, and the K would obviously be slightly on the flatter side. So axial length upon CR ratio in these particular patients, what will happen is it will be more than 3.2 or 3.4. So all these factors do tell you that these patients can go towards myopia. And as soon as you see these patients and gradually try to accumulate these patients, you would realize that gradually you would have a knack about thinking that, okay, this patient looks like a premyope. And normally what I try to do is I will write it on the file itself that this patient is a premyope. And so once you write it down, the next time the patient comes, you are more cautious about that particular patient. So there is no definitive age criteria. Dr. Aval has asked what is the age criteria for PMO. So premyopia, they have given tables in which they have talked from 6 years to 8 years, and then the another batch is 9 to 10 or 9 to 11 years. So age is between 6 to 12 years. That is what premyopia, not the calculator, but the premyopia risk scoring system has done. So they have gone into the age, and so they have tried to separate it out. But the reason why I wanted Dr. Devya to present the article was to tell you that the number is very small. They have got, I think N is equal to 57. So 57 is a very small number when you have a lot of subgroups. When you are talking about 6 years, 7 years, 8 years, so the number is very small. And at this point of time, we are trying to do our own study on premyopia scoring system. And at least in a small sample size in which we did around 150 children, and we felt that at least a scoring system of 5 or more was significant. Whereas if we read that article, it is 4 or more is significant. I think we need a larger multicentric, bigger studies where we can say that, okay, this particular thing is important. And then we can have a better scoring system. At this point of time, definitely if the score is more than 4 or 4.5, I think we should think that this patient can be a premyope, and we can follow him up more carefully, say for 4 or 5 months. And if he progresses further, then we can institute the treatment. So the whole purpose of premyopia or premyopia scoring system is to become more cautious that these patients would progress and these patients may not progress. But we have to write it down that these patients would progress, and therefore we can see them next time whether they are actually progressing or not.
Sir, if you have time, can I ask one basic question, sir? Sorry, query, sir.
Sure. No, we have time because I think Dr. Divya is quite late, so we can talk about
Ji, sir. Sir,
discussion.
yeah, like examination in children, should it be done with tropicamide combination phenylephrine or cyclopent or hometropin, sir? What is in private
So
clinic
we
like?
try no, we try to use hometropin, mainly hometropin. I think we had a long discussion. I think last of the July batch, last meeting, chapter 2, in which we wanted to discuss about what eye drops should be used, and you can use hometropin, you can use cyclopentolate. Both of them are equally good. The only problem that I face with cyclopentolate, because when I was doing my fellowship, I did it from Arvind Madurai. And so when I was doing it, we used to use cyclopentolate. And couple of times, even during that time, we saw some of the side effects of cyclopentolate. And when I was there with Dr. Sharma at RP Center, they were using hometropin. Never saw any patient having any side effect of hometropin. Even at RIU Ahmedabad, I was there did my post graduation from there. And so gradually in my practice, I realized that when I came back, I started using cyclopentolate. Cyclopentolate is a good drop. The only problem is that in a year, you will have at least couple of patients. You will have those psychotic behavior from the kids, and that is a very depressing side effect. Not that anything serious has happened, but it has happened at least 4 or 5 times. And so I realized that it is better to use hometropin eye drops. I'm yet to see any patient developing any psychosis or any problem with hometropin. So right now we use hometropin. That is one. Second is always try to use duochrome and always try to refract over the glasses. It is much easier. So if I'm wearing these glasses, if I try to refract with these glasses, it is much easier to refract.
Fine, sir. And regarding regarding tropicamide and phenylephrine combination, sir, do you suggest, sir, because most of the private clinics, I think that is the dilating drop we use for examination.
If you're using Tropicacil Plus, you should always be cautious that you may have you may over minus the patient. There's a very good chance that you may over minus the patient. So the best way is to do duochrome and try to ask him whether red is bright or green is bright. That is number one. Number two, whenever the patient is fully dilated and comes to you, even if you are in a hurry, before prescribing the glasses, just try to see over the top of glasses with the retinoscope, what is the retinoscopy reading? These two things you will lose maybe 1 or 1.5 minutes. Even in private practice, we can easily do it for 30 seconds. We can take out time in a kid, because otherwise it is very difficult. Either we have to use hometropin to suspend the accommodation, or we have to see with our retinoscope whether there is accommodation is there or not.
Fine, sir.
Something we have to do to make sure that we are not over refracting the kid.
Sir,
If we are
sir, you said after dilatation with the glasses on, we check for the refraction, sir, and confirm if it is okay.
yes,
Is it what you said?
You can take 1.5 in your hand or 1.75
Okay,
and
sir.
just see whether it is neutralizing or not.
Okay.
You keep that handy only. You keep out 1.75 in your hand only with the retinoscope, or 2. So gradually everybody knows their distance. I use 1.5 and 2, both the things. The moment
Okay,
is dilated, comes to my clinic, comes to my room, he is already having undilated autoref. He has best corrected power, and he has dilated refraction, which means dilated autoref. Now,
Sir,
he has come to me for prescription. So what I will do is I will take 1.5. I will keep it in front of the glasses he is wearing, and I will tell him to fix on the vision chart.
Okay, sir.
So he is looking at distance, and I am trying to see whether there is width movement or he is neutralized or not. Yes, Dr. Sir.
So you prefer PMT follow-up, sir, or in the same sitting in the dilatation stage you prescribe glasses, sir?
If there is a doubt, I will call them for PMT.
Fine, sir. Because AR reading is very much different in children, especially because they accommodate AR and this one.
Hometropin, Dr.
Fine. Yes, sir.
I was insisting on hometropin.
Fine, sir. Fine, sir.
Dekho, Doctor Sahab, we have to gradually what happens is you have to set your pattern.
Ji,
So
sir.
somewhere you have to find out ki how can you differentiate between accommodating patients and non. See, you can do it yourself. आपको अपना method निकालना है. What is comfortable at your level?
Fine,
If
sir.
Corticosteroid plus homatropin is not comfortable, then you have to do duochrome before dilating them.
Fine, sir.
Acha, if you feel that you have this thing that Tropicacil has to be used and you want to do PMT, there is absolutely nothing wrong in that. See, we have to find out a way what suits our practice and how we have to build up that thing so that we have minimal errors in terms of over prescribing.
And sir, after with homatropin, like what precautions do you ask them for the next following day? For how many days? Like vision, blur in vision, school, outdoor activities.
At least 24 hours before the blurring goes completely.
Fine, fine, sir. Fine,
So
sir.
typically what I would tell them is that they can come in the afternoon at 4 o'clock.
Ji, sir. Ji, sir.
Next day they can avoid school, but uska next day they can go.
Fine, fine, sir. Fine, sir. Thank you so much, sir. Thank you so much, sir. Thank you, sir.
I think she will still take some time. If you, I mean, we can discuss on that talk of premyopia. Dr. Ankita wants to ask. Okay, she has muted.
Uh, Good evening, sir.
Good evening.
Sir, in the pre-EMO, this risk calculator table, sir, at the bottom they've mentioned that these values of retinoscopy are after 20 minutes of installation of 1% cyclopentolate. Sir, in this case, if we use homatropin, it doesn't really cause a difference, no, sir, in the values.
It doesn't cause a difference. Homatropin and cyclopentolate are almost, they have almost similar efficacy. There's not really a big difference. Cyclopentolate may be a shade better, but if you ask the patient to look at a distance, homatropin, cyclopentolate are comparative. There's no reason to doubt that homatropin will not give you equal amount of cycloplegia.
Thank you, sir.
I think we can. See, this is, I'm just trying to share the slides so that it becomes easy if anybody has any questions. So this was the presentation, and this was what I was talking about, the range of premyopia. And this was the calculator which I was talking about. And this was the question was, what was the age? So at the age of 6 years, 0.75, 7 to 8 years, 0.5, 9 to 10 years, 0.25, and 0 diopter at 11 years. And anybody who loses hyperopia quickly has a parental myopia, does lot of near work, that is there. And if you see this calculator, if you see this, this is what I was talking about. So gender really doesn't make a difference. If you see properly, this is the baseline refractive error is important, and parental myopia is important. If you keep looking at the video, I would be changing the parameters, and if you see the most important parameter that probably that is probably important here is yeah, we can reduce it. Yes. So if you see, once I put this, once I change the baseline refractive error, that is the key, number one. And number two key is parental myopia. The moment I put two parents, But if I reduce the refractive error to 0.5, it becomes slightly higher. If I make it 0, it is like very high. So I think the key to this thing is baseline refractive error, which is this. And the second point is parental myopia. They have not really gone into a huge depth of, they have not really gone into the depth of talking about axial length and AL upon CR ratio. But I think what happens is that as the time passes on, more and more evidence comes. And I don't think that this will stop here. There will be more and more evidence will come. I think somebody was talking about thickness of choroid in premyopes, and then somebody was talking about choroidal vascularity index. And so I think more and more factors will come. These are some of the things. These are some of the risk factors currently. This was the study where they tried to develop and validate a model to predict who will develop myopia. And these are so what they have done is based on what they have done is they have taken out the data from some of the studies, and they have tried to predict the risk of myopia onset the next year. And this is how they have done on three things. So they have gone back on age and spherical equivalent +2. What was the scoring system? Then they have gone on the axial length, anterior chamber depth, and corneal curvature. Then they have gone on whether the myopic parent is there, axial length, what is the axial length and about myopic parent, and they have tried to correlate that. And from all that, they have tried to build this up. So what is my suggestion is that, you can take a print of this, you can take a screenshot of this, and then gradually you can start building up what patients you have and what was their scoring system. Gradually see in, say, 25, 30 patients, whether it is fitting in your system and what is your scoring system where it comes, because the nicer study says that a score of 4 or more is significant, but I think it is a very small number. You can still do your own work. We all can do our work. We can pool our data. We can discuss it out. What should be the scoring system for pre-myopes? This is for 9 to 10-year-old. This is for 6 to 8-year-old. This is for 9 to 10-year-old. So they have taken parental myopia, axial length, and K reading. And this is where they have tried to show whom to follow up, who are the low risk, the scoring between 1 to 3, 4 to 6, 7 to 9, and when to follow up, what is the annual progression, what is the age at which you have to call them back. So all these are, pretty important right now. Two reasons. One is the community guidelines. We in India don't really have a very rigid school screening system. But if you have a better school screening system, you can at least know that when to recall these patients, because they are at a low risk of myopia progression. These are at a higher risk of myopia progression, and so you have to discuss the strategies that environmental modification has to be done. So at this point of time, in all pre-myopes, we should be discussing about the strategies like pre-myopia, environmental factors, near work, more outdoor sitting. So all this has to be discussed. If you feel that there is a moderate to high risk, there is very fast progression of myopia. And so this was one of the studies which was based on the NICER study, where they tried to say that a pre-MO risk of 4 or more is a stronger indicator of future myopia onset, particularly in UK children. And this is what I was saying, that the number was very small. I think it was 57. It was. And this was the Hong Kong study. And this particular 57 was not really their number. They tried to see it from other studies. And this is what they were trying to see. Low risk 1 to 3, likely to be myopic by 16 years of age, 13 years of age, 10 years of age. So that is what is the predictive refractive outcome. And that is where it is important that we should try to find out what is the risk score cutoff. And hyperopic reserve, again, what is hyperopic reserve? We all know that hyperopic reserve means that whatever is the plus power and how much is enough. This was a work which we did with Devanshi, and we tried to make a correlation matrix of all the ocular parameters and try to see which one had higher correlation. And how to manage a pre-myop, obviously, we have to talk about a lot about lifestyle. And that is what is, this is what we talked about, more and more lifestyle modification plans. This is all very similar to chapter 2 class on what are must do, what are important, and what are research based activities. Yes, we have ourselves used low concentration atropine. This was something we published in 2022. And yes, we do try to separate pre-myops into type 1 and type 2. Type 1 being purely genetic, purely based on parental myopia, sibling myopia, and type 2 purely based on environmental types. And we do feel that type 1 are more difficult to treat because they are early myopes. They are more resistant to treatment with low concentration atropine, and they do require higher concentration of atropines. And yes, you have to try to predict as much as possible. And I think this is also a very useful slide where you can take a screenshot from the video itself, and you can try to see which patients are your pre-myopes and which patients do require closer follow-up. So I think all the clinics gradually would require to have their own guideline, and they will have to find out which particular axial length or which particular power is significant for a particular age group. So I tried to get it back so that if you have not seen the video, or if there were any doubts, you can do that. I think Dr. Divya has joined. Divya, are you there?
Yes, sir, I'm here.
You have
I'm really sorry I couldn't reach
Not a
home on
problem.
time.
No. See, the whole purpose of doing online classes is to, try to be more inclusive. It is not possible for all of us to travel, even if, I may be knowing subject little bit better than you, but, we can't do this, and the only way to upgrade is to do it online. And so this is the advantage of
Right.
online this thing. If you have the presentation, you can share, we can discuss it.
Right, sir. I've basically pointed out all, I think you have included all the points which were there in the presentation right now.
The presentation is basically to make sure that it stimulates the discussion. So what we normally try to do is we try to have a presentation very close to what I am going to talk about, and we try to have a presentation on a similar topic so that we can
Right.
stimulate discussion. I may have covered that, but we can still have it, and we can further discuss or build upon it.
Is my presentation visible, sir?
Yes.
I think I am not able to do this full screen, but
Screen, it will come. You press the full screen, it will come. No, you not this. Yeah, press that and press F5. It's fine. You can go ahead and present.
I think it is full screen now, sir.
No, it's not. But that's fine. That's fine. No, it is only you are increasing the size of the slide. That is not full screen. There is a, you can see here, you can press this button, orange button. No, next to that, on the left. Yes. No, on the right. Yeah, the orange button. Comment, and then these are 4 dots. Then there is a reading icon, and then there is a orange button, this play. Yeah, press that. No, you.
Okay. This is
This button, if you can see my. Yes. Please go ahead.
my slides are visible, sir.
Yes.
Hello?
Yes, they are visible. Yes.
Hello?
Yes, you are audible.
Hello?
Yes, can you hear us?
So sorry for the delay for today's presentation. Basically, the paper shows the predicting factors for the myopia onset and progression. So the particular study which we are seeing right now is done in children in the UK, and the predictive risk factors taken were age, spherical equivalent of refraction, axial length, and parental myopia. And it was taken in non-myopic children on the age group of 6 to 8 years and 9 to 10 years. And the statistical analysis was done by Eugen J index by comparing the optimal risk score threshold of pre-myopic risk score, which with the independent risk factors of spherical equivalent refraction less than equal to plus 0.75 diopters, that is nothing but the hyperopic reserve, and the axial length of more than equal to 23.07 millimeters. So the context why this is done is because the low levels of previously it was a concept that myopia of more than equal to 6 diopter can cause the risk factors like myopic maculopathy and PSC, posterior subcapsular cataract. But the new research studies have shown that even the low levels of myopia as low as 3 diopters can cause double the risk of myopic maculopathy and posterior subcapsular cataract and 3 times the risk of retinal detachment. So the factors affecting the rate of progression are basically taken as the age of onset, that is the age of the beginning of the myopia. So the 1 year delay of onset of this myopia can reduce the final refractive power by 1 diopter and also can cause 40% reduction in myopic maculopathy. So that is where this study has taken place. They have created a free online website, myopiaonset.com, where the sir has already shown how it predicts the final risk of myopia. So 4 basic risk indicators which they have taken are age, parental myopia, spherical equivalent of refraction of least hyperopic eye or most emmetropic eye, and axial length. So the NICE study, which we have already seen, it is started in 2006. They have taken 1,000 white children in the age groups of 6 to 7 years and 12 to 13 years and followed them up every 3 years till 9 years. So basically they have defined myopia as the spherical equivalent refraction of less than equal to minus 0.5 diopter. So the predicted risk of developing myopia according to this paper are if the score is 0, it is low or no risk. So there is likely chance that the child can be emmetropic. If the score is 1 to 3, it is low risk and the likely chance of child becoming myopic is by the age of 16 years. If it is 4 to 6, it is moderate risk and the likely chance is by the age of 13 years the child will be myopic. If it is 7 to 9, it is high risk and the child the chances of child becoming myopic is by the age of 10 years. So this is the basic study pattern, and the remaining the charts which sir has shown includes that is all is in the paper. Sir. Sorry for this. Hello.
Hello. Hello. Dr. Divya.
Divya, you can send us the presentation, or we can do it next time.
Yes, sir. I'll.
Am I audible?
Yes, yes,
We can
sir.
do it
Now
next
I
time,
think
not a problem.
Yes, sir.
That
Yes,
is,
sir.
not a problem. We can take a. Acha, acha. So if
sure,
there are any questions, we can take. That is not a problem. We have a lot of time.
right.
Any questions on risk scoring system?
So,
Yeah, please tell that, sir.
So I wanted to know what about the kids who are less than 6 years of age with premyopia onset?
So honestly speaking, see, when the kid is less than 6 years of age, and if the patient has so for 6 year age, we are saying that premyopia is plus 0.75 or plus 1. So if the kid is less than 5 years, at this point of time, if you have a glass power less than plus 0.5, then he is definitely a premyope. So the point being, all the things that are being applicable to 6 years are actually applicable to less than 6 years. Now, at 4 years of age, it is extremely difficult to do axial length.
Mm-hmm.
At 4 years of age, it is extremely, to get a very good axial length, to get a very good K reading, it is slightly difficult. Not really difficult, but slightly difficult. So at this point of time, all the things that are there for 6 years are also applicable for children who are less than 6 years.
Okay. Okay. Sir,
Yes.
so if we feel that in case if we predict or detect premyopia at 4 years, and we feel that the kid is losing the hyperopic reserve quite quickly, so low dose atropine drops can be started in
Two more important things are that his axial growth should be there, because atropine is going to reduce the axial growth. So you should have a repeatable record at 4 years, 4.5 years, that his axial length was progressing.
Okay.
If you have that together with losing out on hyperopia, you can start low dose atropine. There is no reason why you cannot start low dose atropine, because then he is just like a myopic patient.
Mm-hmm. Right. Okay.
Sir, if even if at the age of 4 years the child is giving 6 vision, but after dilation they are showing minus 0.5, minus 0.75 myopic correction. But the child is asymptomatic. He is the parents, or it is difficult to convince the parents also that they need some treatment for either in the form of spectacles or low-dose atropine. So how do we
See,
go about it?
so this patient, you can easily tell that, this patient is a high risk patient. You can just tell the patient that, the patient is high risk. There's a chance that he will progress into myopia. If the refraction is 0.5, it is 0.5. You can tell the patient that this is 0.5. If they say that, no, we don't want to wear glasses, just make sure and just tell them that we have done the axial length. We have the glass power. You come back again after 3 months. See, if the power is 0.5, it will increase by 0.25 and become 0.75. If it increases by 0.75, child will become symptomatic.
Correct.
Once the child becomes symptomatic, they will immediately understand. See, myopia practice is all about waiting and seeing that there is a progression. Without progression, we are not going to do anything. So first time when the patient comes, you should have high index of suspicion, measure and do everything, and then wait for 5 to 6 months. Tell them that they have to do environmental modifications. They don't have to see things from near. They have to sit outdoors, not to, be very close to objects. And if it progresses, then the patient will be, he will be pretty sure, patient will be pretty sure that you are absolutely right, and it has progressed. So that is where we are important, because we are telling them before something has happened, so they would immediately understand that yes, this has happened and this was predicted by the person, and so they would be more amenable to what you are trying to do for them.
So good evening, sir. Once again, sir, please, sir.
Yes, sir. Please, sir.
Sir, since I've missed last two classes, sir, just I wanted some clarification. Sir, what is your guideline for prescribing glasses? Earliest power, lowest power to the children, sir.
0.5. 0.5. We don't
Point-
prescribe the 0.5. Yeah. And 0.5, if it is improving the vision,
जी sir.
then we prescribe 0.5. Normally, it always improves vision. It is not possible that it is not improving vision. See,
Sometimes it's
I
difficult to
will tell you
convince the
what
parents.
happens.
जी sir.
No,
जी
no,
sir.
I will tell you what happens. Those times, what happens is, child is trying to trying to make his eyes small and
जी
trying
sir.
to read through that.
Fine sir. Fine sir.
No problem if parents feel or understand that he's able to read. You can tell them that, see, this is the power. You are not in a hurry of prescribing them. You are there to guide. As a healthcare provider, we are there to guide them. We are telling them that this is the power.
जी sir.
95% of the times, if they have come to you, they already know that their kid is not able to see from a distance.
जी sir. जी sir. 0.5
They're very,
spherical and cylindrical
yeah.
both sir.
Yeah, 0.5 cylinder in isolation, you can leave. But if there is a 0.5 sphere, see, if patient is having only 0.5 cylinder
जी sir. जी sir.
and there are no astronomic complaints and patient is able to read 6.6, there is no point in giving that.
Okay sir. जी sir. जी
So
sir.
in 0.5 cylinder, we talk with the parents, are there any astronomic symptoms? Was it a chance finding or the child was complaining of poor vision?
Fine sir.
Normally, it is a chance finding. Sometimes up to 0.75 also, they don't complain of any asthenopic symptoms. For cylindrical power, I am saying.
Fine sir. Fine sir.
So if there are no complaints, cylindrical power, we don't expect it to really increase. We don't expect 0.75 cylinder to be really amblyogenic. We don't expect cylinder power of 0.75 to induce myopia in future. We don't expect any of these things. So not giving 0.75 is fine. With minus 0.5,
Yes.
definitely, there is, definitely there has to be something. Patient has to have poor vision. The only way he can compensate for that is to, reduce the palpebral fissure size and try to see it by squeezing the eyes or, making them small and try to see. But that also he can't do for very long. And if you have a 6 meter distance, it is difficult for him to see that. He has to move forward. That is where you have to catch hold of the kid, because he may move little bit forward. He may move 1 meter forward and will be able to see 6.6.
Fine sir. And sir, do you prescribe any particular type of glass lenses for this for the children sir, like which
No,
is
no, no,
helpful?
no, 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 not at all, not at all.
They can go for normal lenses. No, no.
Yes, yes.
Fine sir. Fine sir. Thank you so much sir. Thank you sir.
Yeah. So if the pre-MO score is less than 4 but showing lots of hyperopic reserve, LDA can be started if axial length is also progressing. So that is what is the answer to the question, Shalaka. If the axial length is progressing, if patient is losing hyperopic reserve, then you have to give glasses. Normally, pre-MO score will not be less than 4. It will be 6. I have seen patients. Normally, it will not be like that. But if it is less than 4, pre-MO score is only to predict myopia. If you have 2-3 readings where you are seeing that there is a hyperopic reserve which is getting lost and you are seeing that axial length is progressing, then you don't need pre-MO score. Pre-MO score is when the patient has come for the first time to know how much is the risk. If you already have hardcore data with you, you don't need pre-MO score. See, it is very simple. It is like, glaucoma patients. If you know that this patient has glaucoma, you don't have to go for all these scoring systems and GCC and everything. If glaucoma is very classical, you know it is there, it is there. You have to treat that. You can't go with pre-MO score thinking that pre-MO score is superior to your clinical examination. No, no, no. Pre-MO score is only to help you out when the patient has presented for the first time. If you have consecutive multiple readings, patient is losing hyperopic reserve, patient's axial length is progressing, patient is definitely a pre-myope. You have to treat the patient.
Thank you, sir. Sir, also I wanted to assess that you said about binocular vision assessment, sir. So what could you brief on what examinations do we really need to do, and what is the
At least go for cover test, do NPC, near point of convergence, near point of accommodation, look for stereo acuity, and look for binocular NPC, NPA monocular, if possible accommodative lag, cover test just to see any latent deviation, and stereo acuity. That's it. If you really want to go in depth into it, you can look for accommodative facility, because if there is a loss of accommodative facility, that may get augmented with atropine. Accommodative facility loss patients are very few, very rare, and so normally NPA suffices. See, the difference between near point of accommodation and accommodative facility is that accommodative facility is more physiological, more dynamic, and near point of accommodation is just single measurement. So that is the only difference between the two. But normally near point of accommodation suffices. If near point of accommodation is really receded, then you can directly go for glasses. But normally in kids, all these things are not very common. And that is why a lot of people who don't even do it get away with it.
Sir, but in cases where there is any NPA recession, sir, should we give them orthoptic exercises and then maybe start them on glasses or LDA in case of pre-myopes?
See, if you start LDA means some NPA recession will be there, even if you start 0.01%. So I don't think if they have a problem in their accommodative ability, or NPA is receded, or accommodative facility is at loss, I don't think we should venture into using atropine. Better to put them on, defocus lenses.
Okay, sir. Thank you, sir.
Sir, how
Yes.
does atropine control the growth of axial lenses? Like, sorry, how does it? What is its plan, mode of action?
Next talk, Dr. Saab, next talk is on that only. There's
Fine.
a 1 hour 3:30, 1 hour 10-minute talk.
Fine, fine, sir.
I have talked a lot on atropine. It's a very long talk.
Fine,
And
sir. Fine,
so
sir.
initial talks, I was recording them for half an hour. I
Fine,
thought
sir.
that, I should record it. If I record it for 1 hour, maybe the listeners may be bored. Then I started recording at a stretch. So the next talk, chapter 4, is on atropine. It
Fine,
talks
sir.
about various, mechanism of action on the retina, on the choroid, on the sclera, lens thickness, lens power.
Fine, sir. Fine, sir.
Yes.
So, do we have any? This one's a list of talks what we are having, sir. Like next talk,
It
so that
is.
we.
So the next one is on atropine. After that, it is on optical options. Then it is on combination therapy. Then there is on ortho K and red light therapy, and then how to set up a myopia clinic.
Fine, sir. Fine, sir. Fine, sir. Sir, I had few situations, sir, where children they come with complaints of repeated blinking, sir. The parents complain the child
Yes.
is blinking a lot. So few of the cases they were prescribed glasses, and few cases they were emmetropic, sir. So I tried adding them on, putting them on lubricating eye drops, but very often again it reoccurs. It happens again, sir. How to manage such a situation, sir? Sorry.
Blinking normally maybe purely out of watching a lot of television, out of habitual. So if you have done a proper ophthalmic examination and there is nothing, then most of the cases it is not really asthenopic. It is mainly habitual. Because in kids, having asthenopic symptoms is very difficult. Because see, they are not under 6 years of age. They are not really forced into they don't have we don't really expect them to do something, so they really don't have an actual task to perform. They are just enjoying their life. So having asthenopia, and because of asthenopia having increased blinking, is also not very common. So increased blinking, I just saw a case half an hour back. It
Fine, sir.
is more or less habitual. The problem is parents don't accept that it is habitual.
Yes, sir. Yes, sir. Correct, sir. Bilkul, sir. Ji, sir.
So what you have to do is you have to, move in circles. You don't really have a fine answer. There's a very good, survey of ophthalmology. There's a very old article, I think 97 or something, about blinking of eyes and causes of blinking of eyes in children.
Fine, sir. Fine,
But
sir.
if you see the list of causes, and then you find out that bulk of them are actually it is idiopathic. So by idiopathic, I mean that they have seen somebody, They're trying to gather attention. They get attention of parents because they are blinking. So there is no definitive concrete this thing which I can suggest that this would help. So yes, we also do give lubricating eye drops. We try to see if there is any small power which is missed, or is there any foreign body or some foreign body sensation, or some hair which is inverted, or if there are any papillae or follicles which are there in the fornix but not in the palpebral conjunctiva. So we try to see all this, but I would say almost bulk of the patients are at the end of the day, just habitual blinkers, and you have to tell the parents, talk with them, because they have already shown to 3-4 ophthalmologists before you also.
जी
So
सर, जी सर.
you have to tell them that I have done everything. There is nothing that I have with me, and you can use these drops, and if they help, it is fine.
Fine, sir. Fine. Thank you so much, sir. Thank you, sir.
Sir, is there any cutoff refraction where we need to do orthoptic evaluation at a stretch altogether, what the NPA, MPCC, and MEM retinoscopy and everything? For all the myopia patients need to be evaluated for all these parameters.
See, if you are planning to start atropine, you have to do at least once, you have to do a binocular workup, orthoptic workup, just to be sure that if something is arising out of atropine, it has to be because of atropine. So the only reason we push towards doing an orthoptic checkup or orthoptic workup before starting atropine is to be sure that whatever has started has happened because of atropine, and not if patient is already having a esophoria, and once we start atropine and then we notice esophoria, then it becomes difficult to know whether it is the atropine which is causing, or it is it was already there. So that is the reason we stress upon doing orthoptic workup in myopes who are progressing, and we want to start low dose atropine.
When we get a progressive child, we need to go for orthoptic evaluation before starting the atropine, and then follow-up parameters. Do we need to go for follow-up parameters as well?
Yes, at least once. So when you start atropine, you call them after a month, and you do this. So after a month visit, the visit after a month is to see whether how much pupil has dilated, what is the near point of accommodation, whether if patient is having any problems with atropine, and to do orthoptic evaluation.
Thank you.
Take it.
Sir, I actually wanted to ask the guidelines for starting LDA in pre-myopia. Are they the same as that for myopia, sir?
Yes,
Rebound
yes.
effect or tapering,
Everything
is the
is
same, sir?
everything is the same. Everything is the same. It is same for pre-myopes. You should have evidence that they are progressing. That is a baseline to start low concentration atropine.
Okay, sir. Thank you, sir. So the duration is also the same as that for myopia, sir, as we say for 3 to 4 years, and then we have to taper and discontinue, sir.
Yes, the duration is also same. In fact, we try to prolong as much as possible. So it is absolutely the same.
Okay,
The
sir.
good thing
Thank
about starting them in pre-myopia is that you can delay the onset of myopia itself.
Okay, sir. So, but in type 1 pre-myopes, would we like to start LDA along with lifestyle measures at the first line, or should we start first lifestyle measures and then assess and then start on LDA?
Always lifestyle modification as the first thing. See,
Okay,
lifestyle
sir.
modification are the basis. If they are not going to accept that, no other medication will work. They have to agree, accept, and move towards lifestyle modification.
Okay, sir. Thank you, sir.
If there are no other questions, we can call it a day. And the next talk will be on atropine.
जी सर, जी सर.
ठीक है.
When
And
it be, sir, sorry, sir.
yeah, please tell.
Atropine class will be on what date, sir? So roughly, sorry.
No, no. So
Next class.
once we have that video, we will do it next week or
Fine.
in another. Yeah. So first I will post recording for this particular meeting,
Fine, sir.
and then